Thanks so much for joining us for the Cancer Early Detection Seminar Series. Good morning and good evening, depending on where in the world you are today, and we're really excited to have everyone here. Just before we get started, just want to make a couple very brief announcements. Just wanted to mention that we will, as many of you know, that Stanford will be hosting the ACE Summer School, which will be a virtual conference. And so please do save the date. We hope you can join us on this 4-day event from August 30th to September 2nd. We'll be launching the official registration shortly in the next couple of weeks or so. I also wanted to mention another important event this year, which is our usual annual early detection conference, which will be in Portland this year, and that'll be on the 18th to the 20th. And similarly, I think they'll be launching the registration for this as well. So be great to get everybody together in person for this particular event, and looking forward to it again as always. Our next early detection seminar will take place on May 31st, and that'll be from Carolyn Dives. So looking forward to that as well. It's our pleasure today to have Rebecca Fitzgerald present, and I will hand it over to Paul to go ahead and introduce her. Thanks so much.
Thank you, Ryan. Good morning, everyone. I welcome everyone for this month Canary Early Detection Seminar Series. It is my great pleasure to introduce Dr. Rebecca Fitzgerald. She's a professor of cancer prevention and interim director, MRC Cancer Unit, UK, and University of Cambridge. And Dr. Fitzgerald leads a cancer early detection program in University of Cambridge, UK, and which is part of International Alliance for Cancer Early Detection, the EAST program. And she's also a consultant in gastroenterology and cancer medicine and Ottenbrook Hospital. And her group, I think they are leading a program where mainly they focus on detection of this malignant transformation in the esophagus and stomach, and they extract a lot of information and they use those information for designing early detections. And her breakthrough technology invention is a Cytosponge, a device I think they designed to collect cells from the esophagus to kind of use them to determine the Barrett esophagus, a disease actually normally later stage they transformed into kind of malignant cancer, so that they will use this as a kind of system to identify the transformation at dysplasia which is happening in this particular esophagus, so that it provides a lot of early prevention of the disease development by kind of giving early treatment. And this particular device got a lot of attention and won several awards, very few to highlight here, actually Westminster Medal and the PMJ Castro Team of the Year and NHS Innovation Prize and CR UK Jane Wadley Early Detection Prize. And in 2013, Dr. Fitzgerald was awarded, elected for a Fellow of Academy of Medical Sciences. And in 2021, she was elected as a member of European Molecular Biology Organization. And Dr. Fitzgerald is also a Fellow in Medical Sciences at Trinity College, Cambridge. It's my kind of pleasure to invite Dr. Fitzgerald to give her talk on mapping precancer to predict the future, lessons from the esophagus. Dr. Fitzgerald, it's yours.
Thank you very much, and for the warm introduction. Really a pleasure to be here. Get my slides sorted out. So I have very warm affection for Stanford because I spent my first few years of research as a young clinical doctor, just getting into research, and that's how I really got into Barrett's esophagus back in the 90s, 95 to 97, working mainly at the VA campus and working with the GI division. And of course, been getting to know you all through the ACE Alliance. So thank you very much for the invitation, and I'm going to talk to you about esophageal precancer in particular, and how we can map precancer to predict the future and try and identify people at risk of what is a really horrible, poor outcome cancer. So these are my disclosures. As you've heard, I've developed this technology called Cytosponge and related assays, which were licensed to Covidien now Medtronic. And I've co-founded a company called Curative who deliver the laboratory testing. So let me introduce this cancer to you first of all. So this is a cancer that's increased dramatically in the past 40 years or so. This is a slide showing on the top there, the rate ratio relative to 1975. And esophageal adenocarcinoma is here in this black line with this really appalling steep rise in incidence, which I should say isn't, the reasons for that are not well explained. And this increase has been seen particularly in the West and amongst men rather than more than women. And you can see our UK data on the bottom, which mirrors this very rapid increase. Now, there are two graphs I've plotted on the bottom here. One, because there are two main types of esophageal cancer, which I should just make clear from the beginning. So globally, the most common esophageal cancer is squamous cell cancer, which is occurring in the native squamous lining of the esophagus. And that has been declining in the UK and in the US amongst white population. And you can see that the adenocarcinoma is the green line, which has had this rapid increase. So globally, the global burden of esophageal cancer is still predominantly squamous cancer. But I'm going to describe our work to you predominantly on esophageal adenocarcinoma, but the sort of approaches we've developed are absolutely applicable to squamous cell carcinoma as well, if you alter the assays. That device, but that's not what I'm going to discuss today, but absolutely this technology can be applied to squamous cell carcinoma as well. If we look at the 5-year net survival for esophageal cancer, this is all types of esophageal cancer. They have a gloomy prognosis, whichever type it is, unfortunately. So you can see that across a number of different nations here, some variation, but overall, the 5-year net survival is less than 20%. And the main is because patients present late. So the esophagus is a muscular organ. It can stretch to overcome a mass if it's growing so that people can still swallow. You don't feel pain with a lump in your esophagus. So these tumors can really be quite advanced by the time that someone has got swallowing difficulties and losing weight, which are the way in which these patients tend to present to us. But actually this cancer, like many epithelial cancers, evolves really quite slowly from a pre-cancerous condition. And these endoscopic pictures here just show you the different stages of disease. So the precancerous condition is called Barrett's esophagus. That's just named after the surgeon Barrett who discovered this condition. And you can see this deep red salmon pink lining arising from the junction with the stomach. So where my pointer is there, that's the entrance to the stomach. And this salmon pink lining can extend anything from 1 centimeter up to, in the most extreme cases, up to about 20 centimeters up the proximal esophagus. And here is the native squamous epithelium surrounding it. Now, this condition, Barrett's esophagus, is usually undiagnosed. And secondly, it's usually benign. So most patients with Barrett's esophagus will not progress to cancer. Nevertheless, when you do progress to cancer, as I said, the outcomes are very poor. And the progression sequence is through dysplasia, which can be low grade or high grade, through to superficial or in situ carcinoma, all the way through to advanced cancer. So if we look at the progression rate to cancer per year, then from non-dysplastic Barrett's, the rate is about 0.3% per year, and it increases markedly as you develop dysplasia, to the extent that when dysplasia is detected, because of the poor outcomes with invasive disease, we actually recommend intervention at this stage, as I'll show you. And I've just here plotted the 5-year survival ballpark figures for early disease, where the survival is really excellent, particularly when it's detected at the stage of high-grade dysplasia or in situ carcinoma, depending on how far through it goes into the mucosa and submucosa, compared to this poor outcome for advanced cancer. So for this disease type, early detection is really critical. Now, how early is early? Because actually, if we just go back even before precancerous metaplastic Barrett's is visible, we know that in the aging esophagus, we start to get a lot of clonal abnormalities of mutations in bona fide cancer genes, but nevertheless, those individuals remain healthy and do not develop cancer. So there's been some very nice work done in Cambridge, for example, by Phil Jones, by Inigo Martino Carrena, as well as Vogelstein's group, mapping out these mutation clones in aging healthy tissues with Vogelstein's sort of armchair hypothesis. And there's no doubt that as our tissues age, of course, they will some of which, if the conditions are right, can go on. The key to identifying people at risk for this disease is to identify the metaplastic conversion, the precancerous condition, Barrett's esophagus, because that really identifies the people at high risk and gives you a window into therapy. So, although the aging squamous esophagus does collect mutations, the majority of these will remain indolent. P53 is one of the key mutations towards cancer, as I'll show you. So if we just kind of summarize in a cartoon some of the key molecular drivers from benign to malignant disease, as I said, it really starts, I'm not going to focus here on the aging esophagus, although you in the squamous epithelium you will see some mutations there, but really it starts in the metaplastic, non-dysplastic Barrett's esophagus condition. I'm going to talk about the risk factors for that in a moment, but reflux is one of the main drivers. So chronic insult and inflammation from acid and bile exposure. So you can see as you go through the stages that the mutational burden increases from non-dysplastic Barrett's through to a high mutation burden in dysplasia compared to cancer. But what I think is notable is that the mutation burden, even in pre-neoplastic Barrett's esophagus, is really quite remarkably high, even akin to some other invasive cancers. So the mutations accumulate even in patients that don't progress towards cancer. Now, if we look at what those particular mutations are, we see mutations across a number of chromatin remodeling genes, such as ARID1A, SMART4, for example. P16, loss of heterozygosity, is very common very early on, even in non-dysplastic Barrett's, and these patients nevertheless will not progress. In terms of the mutational signature profiles, signature 17 is a real hallmark of this cancer type, and it's been sort of dubbed the acid signature, although it's not been actually proven that acid is the causative reason for that signature 17. If we look at the accumulation of mutations that really confer high risk towards cancer, then P53 is pivotal. We see point mutations, loss of heterozygosity, and we start to see the accumulation of a lot of copy number alterations leading to aneuploidy, including whole genome duplication and other changes such as contagious. Interestingly, mutation of SMAD4 is only really seen in invasive disease. This is what we did for the International Cancer Genome Consortium, and you're going to accumulate other signatures, including SDS3 and 9. So, if you really want to, from a molecular point of view, identify patients at highest risk, P53 and SMAD4 would do it, but the prevalence of mutations are quite low. So, in terms of identifying the people at risk, then precancerous Barrett's esophagus is the condition to look for. The majority of those will not progress. But once you have features of dysplasia, which may be visible pathologically, but from a molecular point of view with P53 loss and aneuploidy developing, then these are the patients that are really and the point at which we would intervene. Now, we have fantastic interventions for a superficial esophageal cancer. It didn't used to be the case. So all of our patients, even if they had dysplastic disease, which was not yet invasive, previously had to undergo esophagectomy. Are treated with endoscopic therapy, which may be removing small areas of the esophagus through endoscopic mucosal resection, or ablation therapy. We have really fantastic ablative therapies, including radiofrequency ablation, which is the most commonly used. So this is outpatient day case type of procedure with very high efficacy. Compared to patients who are the majority of our patients presenting with advanced cancer, so this is invasive disease with lymph node involvement, early hematogenous spread, they're going to require chemotherapy and surgery and around 6 months of treatment. And even then, when they get through all that, the 5-year net survival is disappointing. And then many of our patients, of course, present with metastatic disease when we have to try and really relieve symptoms and give palliative therapy. So with very poor outcomes indeed. So just the data on how efficient and efficacious the endoscopic therapy is. This is data from randomized trials showing the percentage of patients with complete eradication of their disease following ablation therapy. This is an intention to treat comparison with a randomized trial for control or ablation groups. And you can see that whichever parameter you look at, whether it's complete eradication of all Barrett's esophagus, with its intestinal metaplasia is the hallmark cell change, or complete eradication of low-grade or high-grade dysplasia, they do much better in the ablation arm. And this therapy has been shown now to be very durable with outcome data beyond 10 years. So just as a sort of an important aside, really, you might ask me, is Barrett's always the precursor lesion? Do people always go through this precancerous stage, or can you get cancer arising independently of the Barrett's pathway? This adenocarcinoma, for example, could arise from the proximal stomach and can sometimes be quite difficult to determine exactly where in the esophagus the cancer has arisen, particularly when the tumor gets large and it's sitting right at the junction. And the reason this is an important question is because if we're really interested in cancer control, and I'm going to put it out there that we're going to go looking for Barrett's to try and identify more of it, we want to be sure, if that's to be a useful strategy, that Barrett's is indeed, generally speaking, the precursor lesion. So this is a question that we've been interested in for a while, and recently we had opportunity to really delve into this with the benefit of single-cell sequencing technologies. And we performed single-cell sequencing on normal tissues around the junction and Barrett's esophagus. And we used, we're very fortunate to have access to healthy organ donors for this study. And then we could map those single cell profiles onto the profiles from cancer patients. And we also performed a number of lineage tracing experiments looking at the profile, looking at the mitochondrial mutation profile and the somatic mutations to really try an annihilation of Barrett's, and then how the cancers arise. And to cut a long story short, our data suggests that Barrett's esophagus does arise from the normal healthy gastric tissue, and the key transcription factors are c-Myc and HNF4 alpha. And the Barrett's esophagus seems to be always the gateway to esophageal adenocarcinoma, because when we compared the transcriptional profile of the esophageal adenocarcinomas with visible Barrett's compared to esophageal adenocarcinoma where you couldn't see the Barrett's, but it's possible that it had just been overgrown, the profiles were essentially indistinguishable. So we hypothesized that Barrett's does arise from the proximal stomach, which is something that has been really quite under debate and controversial for many years, and that the pathway to cancer is via this precursor Barrett's lesion. So that is reassuring to us that if we're really going out to identify Barrett's as a method for cancer prevention and cancer control, this would be a reasonable strategy. So the practical question then is, why is it that most esophageal cancer presents late, de novo, without knowing that they had Barrett's previously? And why indeed are most patients with Barrett's esophagus, the precursor lesion, not identified? So endoscopy is a very standard, straightforward, effective diagnostic tool. Nevertheless, if you start thinking about the proportion, the large proportion of individuals that might be at risk for Barrett's, and a much simpler, cost-effective way as a triage tool to identify the people with Barrett's esophagus. So the idea is that if you can identify the risk group from the general population, then perform a very simple, cost-effective triage test that will enable us to identify those at risk who are likely to have Barrett's, and then focus our endoscopy services and therapies on those patients who are at highest risk. And that in turn will drive up the quality of the endoscopic diagnoses and therapies, because we can really hone in on those at risk. So who are the individuals at risk? So as I mentioned, this tends to, cancer type and the Barrett's as well, tends to occur predominantly in Caucasians. It affects men to a greater extent than women. The prevalence increases with age. Obesity and smoking are a risk factor. And a key risk factor is reflux of acid and bile, which is often felt as heartburn. And as a surrogate for that, you can identify these people through the medication that they take. So in our screening studies, which I'm going to describe to you, the medication being prescribed for reflux, which we could ascertain through the available drug prescribing databases and records, we could identify the people on these medications who might be at risk. So that's quite an effective way of ascertaining the population at risk. So of course, the more risk factors you have, not surprisingly, the more the prevalence of Barrett's esophagus increases. So in individuals with reflux symptoms, the prevalence of Barrett's is around 3% in the population. As I said, it is also in people age, and now men more than women. If you have GERD plus one risk factor, then the prevalence is up around 12%. The prevalence is high in those with a family history, but family history is rare in this condition, so it's not so useful. And this was a huge meta-analysis to confirm these risk factors. So we've tended to focus on the reflux group and to ascertain that through medication, but one could argue whether you should spread the net a bit wider and look at men above a certain age, for example. So that's the risk group. So the question is, what kind of approach are we going to use then to ascertain people with Barrett's esophagus if we want to get away from endoscopy? And here, when we start thinking about testing so many people, the key kind of prerequisites for a device would be that it's safe, acceptable, low cost, easy to administer. You have to think about all the practical boring but important aspects of how stable the device is, transporting the sample, making sure the assays, of course, are high quality, reproducible, sensitive and specific. And the characteristics, we could discuss this some more, but whether you value sensitivity or specificity the most, of course, you'd want them both to be high. But in a rule-in test in a screening setting, specificity is highly important so that you don't throw out lots of false positives. Now, how does this sit with other early detection tests that you'll be familiar with? So just a couple of words briefly about pan-cancer cell-free DNA tests and breath tests as examples of other things that we're all very excited about. This is data from Grail's publication in 2020 across 50 different cancer types, looking at the sensitivity for oesophageal cancer in particular on training and validation sets. Localizing the tissue of origin was over 90% accurate, so that's very encouraging. The sensitivity for advanced disease is very high, but it drops off dramatically as soon as you get beyond earlier than stage 2. Stage 1, in the current form, the technology is not very sensitive. And if you're interested, as I am, in detecting pre-cancerous Barrett's esophagus, then that's going to be very challenging with this technology. So one of the questions is how early in the disease pathogenesis DNA might be shed into the bloodstream. And when you have an intact basement membrane, you may well not get shedding. So however sensitive your technology, you may not be able to detect it. So I really think which test you use depends exactly the question you're asking. But for me, for trying to detect very early precancerous lesions and dysplastic lesions where your endoscopic therapy is very effective, this may not be the technology of choice at the moment. Breath biopsy, where you detect volatiles, is exciting. It's again quite non-invasive. Different types of technologies out there, but with the same principle. I've just highlighted a couple of studies here. These are quite small studies available at the moment and haven't been tested yet on a kind of population scale. But I think as an approach, this could also be a very useful triage test. The idea that I came up with was a very simple test that could simply collect cells from the esophagus that we could then analyze to identify the cell changes at a cellular and or molecular level to identify the patients at risk. And the reason I favoured this approach was the idea that the esophagus is so easy to access that you could retrieve cells quite easily and inexpensively. And that actually for really a triage test, you don't need imaging. The power is all in the content of the cells and what stage they are on this disease pathogenesis. So, and then you could focus in on your imaging and therapy pathway. So that's the approach that we took. And of course, there are other ways one could do it, but this was appealing to me as a very simple way of going about it. So this cartoon just compares and contrasts endoscopy with the Cytosponge. So endoscopy, excellent tool, of course, very well tolerated generally. Patients are usually sedated. It is quite labor intensive in a way in that you generally have 3 individuals present in an endoscopy managing the airway, the endoscope, and then the cell sampling. You're going to have the benefit of imaging the esophagus and then localizing the areas you're interested in and directing your biopsy at those areas. But the biopsies are going to be tiny pinch biopsies from focal areas. The Cytosponge is a completely different approach. It's much less operator dependent. As I said, you have no image. You're going to collect a sample, which is going to be pretty similar every time. And it's going to be a pan-oesophageal sample. And the power of identifying what's going on is going to be through your assay, because the cells of interest from the Barrett's esophagus, if it's present, are going to be a minority of the population of cells. So the idea is that this capsule contains a compressed sponge. You swallow the capsule down with some water in the stomach environment. It doesn't need an acidic environment, but just warm, moist environment. The capsule dissolves, out pops the sponge, and in its expanded state, it can then be withdrawn by the nurse, and we usually have a nurse deliver it, but the clinical professional, and it will collect a very abundant cell sample as you retrieve the sponge, so upward of 1 million cells. Here's a little video just to show you what that's like. So here's the capsule traveling down to the bottom of the esophagus into the stomach. And here the capsule is going to expand and out will pop that sponge. We wait for 7 minutes to be sure it's completely deployed. And then it's going to be withdrawn in literally a few seconds. So it's going to make your eyes water for a minute, but it's going to be out before you know it. And it's going to collect cells from the top of the stomach and then all the way along the esophagus. And the cells are grabbed in sort of clumps. So it's quite a rich cell sample that you get. And as I said, you're going to get cells from the gastric cardia, the Barrett's, and the squamous epithelium. So there are a number of different approaches you can take to the assay. Because you've got so many cells there, you can really take your choice. So you can look at microRNAs, you can look at methylation, you can look at a mutation panel, or you could go more for a cytopathological perspective and look at immunomarkers. Before I show you the main way that we focus on analysing it, I just wanted to give you some examples of methylation assays, because this idea of a non-endoscopic device with methylation assays seems to have really caught on. So we published in 2017 our work on Cytosponge, which is a 3-gene methylation assay. So with this approach, you don't visualize the cells at all, you just simply extract the DNA and get the methylation profile. It gives you a very promising area under the curve. And other devices have been developed recently. There's the ESA-check balloon, which requires expanding in the distal esophagus. So you just sense the pressure change at the low esophageal junction, expand the balloon, and then do a slightly more targeted sample of the lower esophagus before you deflate the balloon and remove it. And that has been analysed here for 2-gene methylation panel, again giving excellent area under the curve. This is work led by Amitabh Chak in Case Western, published in 2018. And then the Mayo group have worked on their device, which is a similar sponge in a capsule with a slightly different kind of catheter delivery. And again, they're looking at a methylation panel with very promising area under the curve. So that's one way to go. We decided to focus more on approaches that enable you to really understand what was in your cell sample and have the pathological information, because that adds a lot of value. And so the sample processing that we have favored following, interrogation of a number of different approaches is that we spin the cells off to create a kind of pellet. We then make that pellet adhesive by forming an artificial clot around it with plasma thrombin. And this might seem a little bit old-fashioned, you might think, we put it into a block and cut sections, but we get a lot of value added from the analysis of the section. And because we have this clot and multiple sections, we can apply multiple biomarkers to that sample. And this just gives you an idea of the H&E from one of those sections. And the other thing I like about this method is that pathologists are still very used to working with slides, and the clinicians tend to believe what they can see. And they're very familiar with this. So that we can identify here 3 main cell types: the gastric cells from the healthy proximal stomach, squamous epithelium, and the Barrett's esophagus with columnar cells. Now, the gastric cells are a useful quality control because that tells you that the device went to the top of the stomach, and therefore you can be confident that it has sampled the distal esophagus. And the Barrett's esophagus, you can identify it on this H&E, but the addition of biomarkers makes this interrogation much easier and more efficient. And to cut a long story short, the biomarker that we favor to identify the hallmark of Barrett's esophagus, which is called intestinal metaplasia with the goblet cells, is TREF4 factor 3. And we identified this, this was before we had RNA sequencing, and we markers which are highly expressed in Barrett's compared with normal healthy stomach and compared with normal squamous epithelium. And we then wanted a very clean antibody so that we could visualize this through histochemistry. And to cut a long story short, TFF3 really fulfill these criteria of being very specific and sensitive biomarker, not expressed in healthy stomach, not expressed in squamous esophagus, and it's this very clean stain highlighting the goblet cells. Now, the kind of cell, we collect so many cells from this device, this kind of cell pellet that we get on the slide is really quite big. And so you can imagine that a manual screen will be quite challenging, and well, not just challenging, but time consuming to really identify whether you've got any of this minority cell population, which is intestinal metaplasia. But adding the TFF3 makes this much quicker and easier to focus in on the region of interest. And furthermore, you can apply machine learning to help really reduce the time taken for the pathologist and assist both the quality control estimate, looking for the gastric groups, and also identifying the TREF4 factor 3 positive areas, so that from this deep learn classifier, you can get a confidence estimation of the quality control and the diagnostic result. From a regulatory point of view, this assisted machine learning approach in which the pathologist signs it up is much easier to get approved. So this is how a slide-based technology, then using digital machine learning applied to a digital slide, I should say, really makes it very scalable. And this is unpublished work, but the studies we've done today, we've scored the TFF3 in a binary way, so either positive or negative. But actually, there's more value added because you can look at the proportion of TFF3 positive count as a proportion of this whole slide, and that gives you a good estimation of the amount of intestinal metaplasia present, and therefore it's a surrogate for the length of the Barrett's esophagus. And you might say, well, why do you care about the length? Well, we care about the length because actually that correlates quite well with cancer risk. And so potentially, if it's very, very focal, you might not need to worry about it at all. You might not even need to proceed to endoscopy. So again, this can be automated with machine learning so that we can get the TFF3 count and estimate the Barrett's length and give you a confidence level of whether you're likely to have Barrett's present or not. So on to the clinical trials. We've done a number of clinical trials that I'm not going to go through in detail. We've gone rather thoroughly stepwise through proof of concept, primary care screening study, a secondary care case control cohort study, which was powered for accuracy, which we reported as intention to treat. That was really to get a good idea of the sensitivity, specificity going into an enriched population compared to primary care. And then more recently, we've completed a randomized screening trial in primary care to determine the detection rate compared to usual care. And just to highlight those results, this was more than 13,000 patients in England who were all on medication for heartburn, and we could ascertain that directly just by going to their primary care drug prescribing record. We randomized them 1-to-1 to either standard of care or Cytosponge. Standard of care means the GP prescribed the medication they needed for their reflux and referred them to an endoscopy only if they felt it was necessary and they were concerned. And the other half, of course, had the medication, and they were all offered the Cytosponge. And necessary took up the offer, but they were all offered it, and we analysed the data as intention to treat, or per protocol. And the primary endpoint was the number of Barrett's cases diagnosed. And here are the main results. So based on the primary endpoint. So we're interested in the number of Barrett's, or the rate ratio for the usual care arm compared to Cytosponge. So you might say, well, what proportion actually took the Cytosponge? Well, 39% expressed interest. Bearing in mind, this is a letter that just arrives out of the blue saying, would you like, you've got some heartburn, and would you like to have a Cytosponge? And 24% actually participated, some drop out because they were on anticoagulant medication or the time wasn't convenient. And these results are for all of the patients, so intention to treat in the Cytosponge arm, whether or not they actually took up the offer. So what was really striking is that even though in the end 24% detected 10 times more Barrett's esophagus in the Cytosponge arm compared to the usual care, there's a lot of Barrett's out there which is undiagnosed. And if we could get that participation rate up even higher, this rate ratio would obviously increase. What proportion had a positive TFF3 result? That was 13%, and they were referred for endoscopy for confirmation. And of those, a positive predicted value of identifying clinically relevant Barrett's esophagus was 59%. Because there's some focal intestinal metaplasia right at the junction, which is not clinically significant Barrett's, it's just a little bit of focal IM, which can be reassured about. And these patients, this 59%, included people with dysplasia and stage 1 carcinoma. And those 9 patients all underwent a curative intervention. So that was very encouraging. So the clinical evidence base that we've developed to date then for Cytosponge has shown through that series of trials that there is diagnostic accuracy, safety, and acceptability. We did a lot of work really evaluating acceptability by the patients and by the clinicians. The randomized controlled trial data that I've just shown you was a 10-fold increase over usual care. And the health technology assessment has been very encouraging. I'm not going to show you the health economic data, but this was done in collaboration, showing that through a microsimulation health economic model, that this could be a cost-effective approach compared to endoscopy. Now, what happens when you find the Barrett's? So currently in the clinical care, when we find the Barrett's, these patients go into a routine monitoring setup, so surveillance. They have regular endoscopy. The frequency of the endoscopy depends on the findings, but roughly every 2 or 3 years. Biopsies are taken through this, what's called a Seattle protocol. So developed in Seattle, 4 biopsies every 2 centimeters to identify on the biopsy. There is sampling error in terms of identifying the dysplasia and where you take the biopsy. The endoscopy is when you're taking multiple biopsies, it can be poorly tolerated and high cost. So, the question is, how can we do better? Can the Cytosponge not only diagnose the Barrett's, but also be used for the surveillance? So the test I've described to you with TFF3 is really going to tell you, have you got Barrett's or not? But then on top of it, on the same sample, we can do risk stratification to really identify high risk, likely to have dysplasia or early cancer, who need an endoscopy, and the majority who will be low risk, if one could really be confident about that, shouldn't need an endoscopy, they could just go into a Cytosponge follow-up. So is that possible? So what would you use to identify the high-risk patients? So I've already told you that P53 is really a kind of gatekeeper towards Barrett's dysplasia, and it's by far and away the commonest alteration in terms of point mutations compared with other driver genes. One of the challenges we originally thought with the mutation panel is that even in never dysplastic Barrett's, up to 10 years of follow-up in patients with very benign indolent disease, these patients have a smattering of mutations in bona fide cancer genes, apart from p53, which is quite discriminatory between dysplasia cancer and non-dysplastic Barrett's, and SMAD4, but not very prevalent, as I mentioned earlier. So a gene mutation panel, really p53 will tell you most of what you need to know. And this is just some recent work, actually just been published last few weeks, looking at the timing of events in Barrett's progression, just to show you that if you look at non-progressors with indolent disease compared to progressors with high-grade dysplasia and cancer, the non-progressors have far fewer mutations. So this is looking at the different events on the y-axis, and then comparing those that are early or clonal events compared to those that are late and subclonal. And so you can see that the progressors, of course, have many more events. And the key thing here is that p53 seems to really mark that transition point at which they then develop a whole load of mutations and copy number alterations compared to the non-progressors and those who do. As I said, p53 is a very useful biomarker then. What's the most expedient way to do that on a cytosponge sample? Well, actually, straightforward old-fashioned immunohistochemistry does it pretty well. There are two different patterns of immunohistochemical abnormality you can see. Usually there is overexpression of the protein due to abnormal stabilization that you can detect as dark brown staining. Sometimes you can get an absent null pattern, which is rather more difficult to detect on cytosponge. But the aberrant p53 can be easily identified. So in our recent work then to try and really understand if you can use a cytosponge not only for screening, but also for surveillance, for this study, we used a marker of atypia, just simply, histopathological criteria of atypia and p53 overexpression. And we were also interested in whether clinical risk factors add any value. And we started off by looking at 17 different clinical risk factors to boil down on those which are really essential. For the study design, we did a retrospective training study, cohort of over 500 patients, then a retrospective validation cohort over 300 patients, and then a prospective cohort, which was the real-time diagnostic risk evaluation. And the results of that study was that we were able to come up with a decision tree for cytosponge surveillance. So these are patients with Barrett, so they're TFF3 positive. If they have atypia and or p53 overexpression, then those are patients high risk who need an endoscopy referral. And really the atypia and p53 are pretty powerful, just as those two simple biomarkers. If it's negative for p53 and atypia, then the clinical factors can add some information. So patients who have longer segments, at what's this M and C is a length classification criteria that we use called Prague. If they have longer segments or a reasonably long segment, but they're male or older age, then they're moderate risk, and you might put them through a more frequent cytosponge follow-up or alternate with endoscopy. Patients who are biomarker negative, who have no clinical risk factors, it's a short segment, they're female, they're not very old. Those patients, you can be pretty confident that you could just manage them with cytosponge surveillance. Just to put some numbers on those, this is the risks across the training and validation cohorts over 891 patients. You can see here the distribution across non-dysplastic Barrett's, low-grade and high-grade when they were endoscoped, and those that we categorized based on cytosponge as high risk, moderate or low risk. The majority of patients with high-grade dysplasia and low-grade dysplasia. The moderate group will scoop up the other few patients that we're going to still keep an eye on. And the low risk is going to be less than 2% with any dysplasia that we could miss using this approach. And these aren't going to be discharged, they're just going to be put on a different follow-up regime. So we were very encouraged by the value of cytosponge or the potential use of cytosponge for surveillance. So the yield of high-grade cancer in the high-risk group, just put some numbers on this, is 47% versus a strategy of endoscoping everyone, where the proportion we pick up with dysplasia is about 14%. And the miss rate in the low-risk group would be less than 2%. Here are some case studies just to bring that to life. Because one of the interesting things is patients where you find something on cytosponge, but you don't find anything on endoscopy. And the middle panel here shows you a male patient age 57 with a short segment of Barrett's. The sample looks quite abnormal with atypia and a p53 overexpression, but the endoscopy didn't show anything. those cases, we would suggest that there may be sampling bias and the patient should be kept under close review and have a repeat at 6 months. And we've got examples now of where patients then in the repeat, the cytosponge has again been abnormal, and then on the repeat, the endoscopy has found the dysplasia. So, you know, the gold standard endoscopy is not always the perfect test.
So I was just saying that, you know, once identified, the patients at high risk really benefit from state-of-the-art endoscopy and fantastic collaborative work we've been doing with Sarah Bondic, who was at Sangambir's lab, of course, and working on multispectral imaging as a really ideal way to avoid sampling bias and identify the dysplastic areas that then can be treated. Autofluorescence endoscopy with confocal is another approach. The last thing I just wanted to say was about DNA copy number and how we really leverage this and potentially identify this on Cytosponge, because copy number is the other key marker which identifies high-risk patients compared to those with indolent Barrett's esophagus. And I'll skip through this for the sake of time, but there's really a big change compared to progressors versus non-progressors that we can identify using shallow whole genome in their copy number status, which is very cost-effective way of looking at copy number genome-wide without knowing on which particular genomic locus you need to focus on, because it is very heterogeneous across the genome and varies between patients. And just to show you that on the shallow whole genome, we can really pick up patients who are likely to progress versus patients who are not likely to progress, just based on a shallow whole genome 0.4x sequencing. And this just compares the results across time and space for these patients that we classify as low risk versus high risk, where the red dots are high risk and the blue low risk, looking across the esophagus for a whole series of patients. And the cool thing about this shallow whole genome approach is that the changes really occur in the copy number status many years before they progress to cancer. So this is bar chart is just looking at time to progression. And obviously at their endpoint, 93% have identifiable aneuploidy on their shallow whole genome. But even 8 years before progression, up around 50%, you can already see that there are copy number changes. So you can really start to predict patients at high risk sometime ahead of when they will have visible dysplasia. And we can apply this to cytosponge samples as well. So the current data I've shown you in terms of the surveillance is really based on dysplasia and p53 overexpression, but there's the potential to add in copy number change as well. And this is a paper just to bring to your attention using a alternative approach, but a similar concept using RealSeq. So this is a massively parallel sequencing approach with sort of reduced representation to identify aneuploidy from endoscopic brushings. So just to finish then, we think that this approach with the Cytosponge could identify the individuals at risk in a screening setting, but then also in a surveillance or monitoring setting, discriminate those at high risk from those at low risk. And if you can really focus down on those at high risk, you can then do high resolution endoscopy and therapy on the people who need it. So I think I've convinced you that precancerous lesions, so even stepping back before invasion, are an opportunity for early detection and cancer prevention. And we think that doing this with a new generation of non-endoscopic devices and biomarkers is a feasible option. We've got randomized trial evidence for our TFF3 approach. P53 and atypia can be added in for surveillance, and copy number can be also a very useful biomarker. Just to finish with, it's a real pleasure to be part of the ACE Alliance. Our early detection program has been going for a little while in Cambridge, but just to say that we're actually about to launch a new physical institute for early cancer in Cambridge, which will really focus on inventing new technologies and strategies to distinguish between patients with benign compared to malignant lesions in order to prevent progression to lethal cancer and obviously improve outcomes for patients. We are focusing on a number of different cancer types, but particularly those with very poor outcomes. We're working across technologies. You know, if any of you would like to collaborate with us, or if you're interested as an early career researcher, we have opportunities coming up with new posts available in our new institute. And as part of our ACE Alliance, we also have a patient-facing clinic to test new technologies. And that's open to collaboration across the Alliance. And as part of that clinic, we're also recruiting volunteers, so healthy individuals, in which we'll have a pre-consented recallable cohort with longitudinal data and a lot of samples we're collecting, both blood, urine, etc. That will also be a resource, we hope, for the Alliance in the future. So thanks a lot for your attention. I'm very sorry for my internet failure in the middle, and these are the people that I should acknowledge, because obviously the work that I've done over the years is a massive collaborative effort, both from within my own group and collaborators, both in Cambridge and at other institutions, particularly King's and Queen Mary University of London, and a great interdisciplinary team as well. So thank you very much. And of course to my funders, without whom this work would not be possible. So thank you again for your attention, and happy to take any questions if time permits.
Yeah, thank you, Dr. Fitzgerald, for a great talk. I think now we have, I think, a few minutes for question and answers. I have two questions in the chat section. Let me read it. The first question is from Dr. Kerr. And are there any effective non-surgical treatments that can prevent or delay progression of dysplasia? For example, changes in diet and or weight.
Yeah, good question. So there's often the studies on preventative measures are not sort of large-scale randomized type trials. Certainly obesity is a risk factor. There's not really good data to show whether if you then lose weight, that's protective. There is a large chemoprevention trial called the Assay trial, published a few years ago, looking at proton pump inhibitors, so acid suppression plus or minus aspirin in the 2x2 factorial design, to see if that prevented progression to dysplasia. And there was some efficacy of the proton pump inhibitors in particular. But you know, the intervention endoscopically for early disease is very straightforward and very effective outpatient procedure. So yeah, I'm sure we should pay attention to preventive strategies, but also actually the surgical intervention for this particular disease when it's early is great and pretty well tolerated.
Yeah, thank you.
Yeah, the next question was about, have you explored additional uses like capturing the microbiome or isolating live cells for treatment monitoring? Great question. So you can certainly study the microbiome from this sample, and we've published one study looking at that. You get a lot of material from the mouth, which of course is very rich in microbes. So we also collected a throat swab so that we could sort of do a subtraction analysis to identify organisms that had come from the esophagus rather than the mouth. And you know, of course, the challenge with many of these studies is proving cause and effect, and you find a lot of stuff, and the question is what's really meaningful. But certainly you can study the microbiome, and we're just actually exploring a collaboration at the moment to expand on that work. And the good thing is you can do it from the supernatant. So you get additional information from the supernatant without using up more of your sponge. And you can, a lot of the cells are superficial, on the superficial layers, so they will be generally the, you know, apoptosed cells, fully differentiated. It'd be hard to culture them, but you can get, you do collect some cells from the suprabasal layers as well, and you can indeed culture them. So we've explored it a little bit. We haven't really pushed it out, but you could potentially grow them, and you could look at treatments, but there may be easy way of doing it actually than necessarily on the Cytosponge, because you just get so many cells and lots of them are squamous and lots of them will just be dead. The DNA yield, I mean, you get copious cell yield and hence DNA yield from the Cytosponge, because you get upwards of 1 million to 4 million cells. The thing is, though, that the majority are the healthy cells. You know, you've got a normal gastric, normal squamous, which would be the proportion, and your Barrett's will be a fraction, and then your dysplastic Barrett's will be even a smaller fraction of that. And depending on the length of your Barrett's, that cell proportion is likely to be anything from 5% tops downwards. So it's some of the same challenges actually with cell-free tumor DNA, in terms of them making sure that you've got sensitive enough assays to pick those cells. So the other thing you can also do is, and we did a bit of exploratory work with Utkan on this, is ways of enriching the cell population of interest using microfluidics or levitation devices or different approaches, so that you actually separate out the cell type that you're more interested in if you then wanted to do something on that enriched fraction. But that's again why the cell pellet and sections gives you a lot of information, so you know exactly which cells you're interrogating within the sample, and then you can extract DNA from those. It's another way of doing it.
Yeah.
But for the antibody work, we then extract the DNA from the block from the cells of interest.
Yeah, thank you. Is there any other question? If not, I will put a last question before we close the talk. Did you notice any particular P53 mutation that is predominant in this neoplastic transformation in your particular assay system?
Yeah, I mean, there are. It's not. I mean, some of the well-known P53 hotspots are definitely there in this disease type, but actually, you get. We have delineated them all as part of the ICGC work, so you get quite a spectrum of mutations. You get the hotspots there, but they're quite heterogeneous. Loss of heterozygosity is also quite.
Right now, your consideration is only the overexpression of P53. Right now, your consideration is only the overexpression of P53, not the specific mutation, right?
Well, no, I mean, so we have looked at, and when we've done studies on biopsies and things, we absolutely look at, you know, transcript. We've looked at different, you know, we looked at the mutation profiles, and we've looked at overexpression and the absent pattern on the staining. On the Cytosponge, because of the way that the cells are collected and the sample is sort of organized, it's harder to get the wild type comparison to really be confident about the absent pattern. So generally we would call the overexpression but not the absent, but yeah, all are irrelevant. Just on our Cytosponge sample type, it's quite difficult to call the absent pattern, but that's a minority of the staining pattern actually that we see for P53 in this cancer type.
Yeah, thank you so much. Utkan, do you have anything to ask her, or?
Thank you very much, Rebecca, for the presentation and opportunity to hear your wonderful talk. I don't have any other questions. Just thank you.
Okay, then thank you so much for the great presentation. Happy to see you again. Thank you.
Thanks everyone for having me.
Thank you.
Sorry again about the internet issue.
Yeah. Bye.
Well,
Okay, bye-bye.
thank you.
Bye. Bye.
Bye. Thanks, Paul.
Bye.